Good afternoon, everyone, and welcome to today's webinar. My name is Xavier Biggs, your PANCAP Knowledge Management Vice Chair and Monitoring and Evaluation Manager at Jamaica AIDS Support for Life. Very happy to be your moderator today. Let me extend a warm welcome to you on behalf of the PANCAP Director, Mr. Derek Springer, the Knowledge Management Working Group. Again, thanks for joining us. Usually before we get started, we just like to clear some logistics. We encourage that you keep your microphones muted for the duration of the webinars. We will take both presenters first, and if you have any questions, feel free to ask by using the chat box to the right. We will be introducing a poll activity, or we have introduced a poll activity that will ask you to answer questions at different points throughout the webinar. We encourage your participation. And at the end of the webinar, we'll also be sending you an evaluation, and we use your feedback to make the presentations better. The webinar is recorded and will be shared after the session so that the broader community can benefit or for greater partnership. All right, so today we'll be hearing from Dr. Ayana Sebro and Cheryl Johnson. For those of us who weren't here yesterday, Cheryl is a technical officer on HIV testing services within the HIV department at the ministry. Sorry, let's do that again. Cheryl is a technical officer on HIV testing services within the HIV department at the World Health Organization. She is a WHO lead on HIV self-testing and supports multiple implementation research studies and countries who are starting and scaling up self-testing. She led the development of the 2016 WHO Consolidated Guidelines on HIV self-testing and partner notification, and most recently, the WHO self-testing framework. Our second presenter today will be Dr. Ayana Sebro. Dr. Sebro is a well-rounded preventative medicine physician with interest and extensive experience in HIV and its related diseases. He currently serves as the technical director of the National AIDS Coordinating Committee Secretariat. So, Cheryl, are you ready?
Yes, thank you so much for the introduction. So good morning or good afternoon, depending on if you're on my time zone, but I'm imagining most of you is your morning. So thanks for joining to hear about self-testing today. So I'm just going to go in this presentation a little bit about what self-testing is, about our guidelines, and then some of the experiences and lessons learned that we're seeing, particularly in the Caribbean region, but also that may examples that may be coming from other regions that are potentially applicable as well. So I think this is just a helpful framing slide when we start to think about why we're talking about self-testing and some of these innovations is, to think about our first 90 progress. So in terms of the number of people with HIV who know their status, as our big target is really to reach 90% of those with people with HIV, so they become aware and then that they can access treatment and become virally suppressed. So we have a number of countries that are really progressing, but we still have a significant gap. So 25% of people with HIV remain undiagnosed. And when we really dig into that number, the majority of these groups are men, key populations, and also some young people, including young key populations. And when we think about the progress towards the 90-90-90 in the Caribbean, we really do see that, just to look at the bar chart to the left, that the percentage of people with HIV diagnosed is below kind of that global average. So there is a gap, and we need to be thinking about how we're going to reach the remaining people in the region. And globally, and both also in the Caribbean, a high proportion of the new infections and number of people that are most affected by HIV are key populations and their partners. And so we're seeing, now globally, more than half of all the new HIV infections reported in 2017 were among key populations and their partners, and even more than that, so around 68% in the Caribbean region. And this really, I think, is helpful to kind of then interpret some of the trends we're seeing at the countries in the Caribbean region, looking at the total number of people with HIV and the new infections. So then really starting to see, okay, the proportion of people with HIV who are diagnosed, really thinking of some countries are on their way. Others, I think we are thinking about how we can really work to optimize service delivery of testing and reach those that aren't accessing the existing services to really close that gap. So I'll talk to you a little bit about the guidelines that we have. So we have three kind of key documents that are helpful guides. So the 2015 Consolidated Guidelines on HIV testing more broadly, the supplement, which is on self-testing and partner notification, and now the brand new guide for planning and introducing and scaling up self-testing, particularly if you're operationalizing those guidelines. So what these kind of guidelines really summarize is the recommended testing services. And so there's a variety of different modalities or locations in which HIV testing can take place. And that's really important because testing is this key gateway to treatment and prevention for individuals, couples, partners, and families. And it's just important to think about what's the best way to reach those that are at high risk and in need of testing. So the standard facility-based testing, which is offering HIV testing in health facilities, that could be a VCT integrated into a hospital setting, inpatient or outpatient clinics, ANC, TB, STI, family planning, the list goes on. Community-based testing is defined as offering testing in the natural setting of the community. So this is outreach, community-based organizations, workplace programs, clubs, bars. There's lots of mobile vans or other things that may be already used in your context, but a really important strategy, particularly for those key population groups or those that don't come into standard services. And then we talked a little bit about this yesterday, was the assisted partner notification method of assisting individuals with HIV by contacting their sexual and or drug injecting partners and offering them testing services. And this can take place in a facility or a community setting. And it actually can also be used with self-testing as well. And then today we're going to really focus in on self-testing as, offering the self-test kit to an individual or their partner to enable them to collect their sample, which is oral or blood, and perform the test and interpret the results in private. So this is really just a quick summary of what we'll talk about. And when we talk about self-testing, some of you may have heard of self-specimen collection. So in the early days of an individual who could collect their specimen, most likely finger prick, and then they would send that in the mail to a lab who would then call and return those results. Now that's self-collection, and really we won't be talking about that today. We'll be talking about self-testing. So when a person collects their specimen, performs the test, and interprets their result right there. And this is important because then all reactive results need further testing. And I think that we'll dig into a little bit about what we mean by that. The other thing that I think is important when we talk about self-testing is it's more than just a kit. So there's a variety of support tools and service delivery models that we'll go into, but some of the support tools to be thinking about with the self-testing package are things like in-person demonstrations showing people or explaining how to self-test, how to interpret those results. That's something that's been utilized. Demonstration videos that come with those kits, telephone hotlines that having that information inside of the instructions for use or on the box is really useful and can be integrated into existing national hotline services, as well as short message services that work similarly, and then other educational information or local resources. So it's just a reminder is throughout this discussion of what self-testing is and the guidance, this package of support tool is just going hand in hand throughout. Another important thing to think about is when we start with self-testing, often a lot of countries or programs are asking, well, can't we just use our professional use tests and give them to people so they can self-test? So what we really want to emphasize here is that self-testing is designed, it's products that are designed for self-testing. So I'm just showing you here an example of some of the professional use tests and then some analogous versions of the self-test version of maybe that exact same test. So for instance, this Chembio SureCheck HIV 1 and 2 test, you might see something like this in a professional use setting, but then it could be repackaged in a box like this one, just as an example, and that would be designed and validated for self-testing. Similarly, here you're seeing another INSTI HIV test that many of you may have seen in the professional use setting, but here I'm showing you the version that's actually sold for self-testing, which is slightly different with different instructions for use, or is optimized for that individual lay user. And then lastly, the OraQuick HIV test. So you might have seen this in professional use settings with the blue tube kind of vial holders, so for multiple kits that could be put there. And the instructions for use you can kind of see to the far left are very small. So that's really designed for a professional tester, where then to the right you see the instructions for use that are packaged with the self-test version of that product and that have really been validated for use to optimize the accuracy and performance and the usability of the product for the lay self-testing group. So I think it's also important when we talk about self-testing just to kind of be upfront about the products. And this is a list of the self-testing products with either with WHO pre-qualification. We have one product that's WHO pre-qualified, which is highlighted in green. But then also here I've got listed products that have a expert review panel for diagnostics. It's a expert body that's hosted by a Global Fund and WHO. And really before a product is pre-qualified, if we want to help get something into the field for operational research or so a country can explore, this is an opportunity where you can procure products using Global Fund resources. And so these are ERPD risk category 3. And really what that means is you can potentially purchase those with donor funds to explore, but it's not something where it has like a full WHO qualification and is for scale up. And then also listed here are products that have CE mark or FDA, and if there were products approved by other founding members of the IMDRF, those would also be listed here as well. But it gives you a sense of the sensitivity and specificity of the products in the market. The prices vary across countries, so it's very difficult to say. But you can see there's a number of options in terms of the blood-based products, and there's one product for that uses oral fluid. And when we think about self-testing and talk about it in our guidelines, when you're thinking about which products to select, it should really be products that are highly sensitive and specific, simple to use, that have the necessary consumables, so swabs and plasters included that are needed, say if it's a finger prick self-test. And then they should provide results that are easy to read or interpret for a lay user, that are available in a short period of time. So those products I've just showed you, they provide results in between 1 to 20 minutes after the test is conducted. And then it's always good to say that these products should be able to be disposed of in the general waste system. And all of those products listed there, they can be. So finger prick products, they all have retractable lancets and have been designed so they can be disposed of in the general waste system. And this is the same for the oral tests as well, all designed to be disposed in general waste systems. The self-test should also be accompanied with the clear pictorial instructions, the support tools I mentioned. There's a variety that can be chosen from depending on the context. So you don't need to have necessarily all, but something that's relevant for the context and the information on what to do or where to go after self-testing. And I think also important just to underscore, products, that may not have good stability, that can't sustain suboptimal storage or are not robust and cannot sustain common users. Those might not be ideal for self-testing. And so it's something where if it's not listed by one of those bodies that I've kind of shared, and maybe it's something locally, this is a checklist of things to be thinking about when selecting products or thinking about that. But other considerations as well are cost, and then options such as blood and oral, offering different options. So that's just like a background of what is self-testing and the types of products that we talk about in the guidelines and some general guiding principles. Now, within the WHO guidelines, it's important to know the self-test, it's considered an assay 0 or a test for triage. So all reactive results require further testing. So you can kind of see through this diagram, if somebody were to have a reactive self-test, that person would be advised to receive further testing for diagnosis. So they would get the full HIV testing algorithm from the beginning at a facility by a trained tester who would then confirm that, and then onward linkage to treatment as in the existing system. And if this person had a negative self-test result, this would be considered negative. If this person was at high risk, say coming from a Q population, the existing recommendations on retesting, so if this person is on, needs to be retested every 6 months because they're coming, say they're a sex worker in one of these high risk populations, that would be something that we would want to reiterate, and important to have that type of information in the package insert. And it's something as well, if somebody has a recent exposure in the preceding 6 to 12 weeks, then they should also be encouraged to retest. But that's an existing recommendation with any test that's done in a facility. So something where it's not too different, but something to underscore. Also, it's important to note that self-testing is not recommended for people taking antiretroviral drugs. So this could be for treatment or for prevention. And this is because it could have an effect and cause some false negative results. So sometimes we do know that people that are on treatment who know their status may test in facilities or may want to self-test. So it's really important the messages are provided to ensure that that is not occurring, or encourage folks to get viral load testing and to ask questions and speak to a counselor if that's really what they need. And I think for individuals on PrEP at this time, we don't recommend self-testing for people taking PrEP, because those quarterly facility visits are such a priority for that group. And it's not just about HIV, it's also about STIs and other services. So it's really important to continue to encourage that. And then, as always, any person who's uncertain about their self-test result should really be encouraged to access facility or community-based testing. So now to kind of shift into some of the evidence. So when we talk about just what self-testing is, as part of the guidelines, we did a systematic review and meta-analysis looking at the accuracy and reliability of the results. And what we really found was that lay users can perform rapid diagnostic tests for self-testing, as well as trained health workers. So really encouraging results to said that, given good products, given the right materials, individuals can do this. And we also identify that there may be some areas to improve. And so this is something to always say, that instructions for use and packaging are really important to optimize performance and reduce errors. And that really goes back to that early slide I showed around, why a professional use test isn't necessarily something you can just give to someone to self-test with, because you do need optimized instructions for use, and you do need different packaging and information that's going to help a lay user who is different than somebody who's a professional and trained tester. Then just to summarize some of the other evidence in the guidelines and some latest data as well, from our systematic review looking at the effects of HIV self-testing compared to standard testing, we saw that it doubled uptake of testing, doubled partner testing, doubled the frequency of testing among high-risk men who have sex with men, and then it also diagnosed more positive people. And since that systematic review came out, now we have 4 randomized controlled trials that have shown self-testing to identify a greater proportion of positives versus facility-based testing. So that's occurring because by increasing testing coverage among a high-risk group of people, or testing frequency, identifying more of these positive cases is just more likely. So I think that anything with positivity or case finding, that's always going to be based on the population you're focusing on reaching. And I'll get into a little bit around how self-testing can be utilized in service delivery models to do that, but just something to take into consideration. And in addition to these outcomes, we had done a previous review looking at the acceptability of self-testing, particularly among key populations, and showing really high acceptability globally. And then in this bar chart, it's just to show that on HIVST.org, which is a repository of evidence on HIV self-testing, which if you're ever interested to check out the latest literature, is a very good resource, really shows that self-testing has continued to be highly acceptable globally and in the AMRO region, particularly among key populations. I think also we recognize that with self-testing early on, there was a lot of questions around potential social harm or adverse events. But when doing the guidelines and since the guidelines have come out, we've continued to monitor, look for these outcomes. And to date, studies report self-testing can be empowering. When looking at those RCTs that I showed from that systematic review, and to date, social harm due to self-testing has not been identified in any of those RCTs, and reports from other observational studies are limited, and they didn't suggest that self-testing increased the risk of harm. We've also monitored the implementation of over 1 million self-tests in 6 countries, and there were no suicides or self-harm incidents. And the cases of social harm that came up were not directly related to self-testing across this monitoring, but were issues affecting communities like serodiscordancy, breakup, and couples that had a history of intimate partner violence prior to self-testing. And then individuals and communities, they continue to report the potential benefits of self-testing outweighs the potential risks. And I think that's such an important message to continue to reflect on, to say, when it comes to HIV testing, depending on the context and the person, there's going to be a lot of different things to consider. But communities and individuals continue to see this as a useful approach, and that really does have some weight. And I think even though these findings are encouraging, programs still need to consider how to provide clear messages to address potential harm, and monitoring and reporting are really important. There are a variety of tools, such as those hotlines or mobile phones. There's been some success with community-based monitoring systems, as well as some computer programs, and then existing post-market surveillance systems that can be utilized. And here's also just a link as well. WHO has a form for complaint reporting. So this is something countries could adapt or also use, and we collect and aggregate those at WHO. So we're always happy to receive those. And so encourage you, if you are doing some self-testing, to take a look at that. So in short, just the recommendations after viewing all of that information, and expert group came out with a recommendation on self-testing in 2016, summarizing that the key evidence showed self-testing was safe and accurate, highly acceptable, that it increased access and also increased uptake and frequency of testing, particularly among these high-risk groups that may not test otherwise, and also diagnosed more HIV positive people. And so this is just the existing recommendation in the guidelines. And I just wanted to highlight here is there's so many different models of self-testing, ranging from a community-based delivery model to facilities or partner delivered. And I'll touch on a few examples that might be particularly relevant for this region, but it's also important to think about what works best for reaching those that are missing or that are not being reached by your existing testing services when kind of selecting those models. So since the guidelines have come out, we now have 59 countries with policies on self-testing, and of these, 28 are implementing. We've also identified 32 different pilots on self-testing. I think there's probably many more, but 32 large-scale pilots, and there's an additional 53 countries that have policies that are under development. And I just highlighted a couple that were in the EMRA region that either have a policy that is implemented or that have a policy but it's not yet implemented, and then the policy that's in development. So it seems like there might be a couple of countries thinking about this, but excited to learn where things are, how things are progressing from any of those calling in. And I think we're also starting to see the market for self-testing increase. So we released the first forecast on self-testing just in July as part of the UNITAID landscape report. And what we're seeing is that by 2020, the global market for self-testing would be around at least 16 million and could be significantly higher as well, and considering the conservative or moderate scenarios. And we're also seeing, I think, some growth in the private sector. And here, it's very interesting to see, in the Americas, it's expected that this region will provide a strong foundation for private sector volumes for self-testing as well. So another component to be thinking about, not just a public sector model, but the alternative public-private partnerships or other methods that could be considered here. So as with all testing, self-testing should also be focused. So in the strategic framework, we really highlight that using self-testing, it's about reaching the largest possible number of people with HIV who remained undiagnosed. increasing acceptability, equity, demand by reaching those that are left behind or that are unreached by existing services, ensuring cost effectiveness or cost neutrality in many cases, and ways that self-testing can be a tool to create greater efficiencies perhaps for the health system and for users. So this sometimes comes up for programs that are thinking they're using a lot of health worker time to deliver community outreach or to do partner notification, and maybe the self-testing tool can be integrated into those services to help expand coverage and optimize health worker time. And also really should be geared towards helping achieve the existing national program targets, national and global or other even fast-track prevention targets. And then always important to consider the facilitation of linkage to treatment for individuals who test positive and providing that appropriately tailored prevention for those who do have a negative test. So when thinking about where to begin with self-testing, I think there's a number of dimensions, and it's knowing your epidemic and your testing gap, so which populations often, the approaches that might need to be considered or that you are already offering, and then the considerations around the risks or the benefits to the population, the support tools that match to those different delivery models, the linkage needs, and then what's really going to help increase access and coverage in your context. So just as an example, if you're thinking about using self-testing to reach key populations, you might first start thinking about community outreach or demand creation if you're doing a PrEP program and you want to reach more key population groups and tell them about PrEP. That could be one option I know some countries are exploring. Also internet and apps and e-testing, as well a variety of other options. And say if you're thinking about maybe serodiscordant couples or partners of people with HIV, you could think about maybe integrating as well into some facility programs that are really targeted and then integrated into contraceptive services potentially, or the partner delivered model where you're looking at providing a self-test to somebody who's been recently diagnosed so that they could give a self-test kit to their partner. And so just to highlight a couple of high yield approaches that we've seen some data on. So this partner delivered approach, this model where an individual that is an ART patient or has been recently diagnosed with HIV provides a kit to their partner, has been showing some really encouraging results. So to the left here, I'm showing you some early data coming out of Malawi, where they provided self-test kits to ART patients, and they compared this to those that were just receiving a passive referral slip, the PRS. And what they really found here from those that they followed up was that the self-test did increase testing uptake. So 79% of those who got the self-test, they opted to test versus 27% of those who got the referral slip. And then we identified more new positives compared to those just receiving the passive referral slip. And then the social network model is another one that's been very interesting to watch. So this is where an individual from a high-risk network, they are given multiple self-test kits, maybe 3 to 5, that they then distribute to their high-risk network. So this could be something for men who have sex with men or female sex workers. And so just showing you an example here in Kenya, they had community-based testing to the left in that table, compared with self-testing via the social network, where men who have sex with men had 5 kits that they could then distribute to their key contacts. And what we really see here is that more cases of more individuals who were positive were identified in the self-testing via social network group. And we also had quite good ART linkage. And I would highlight here in this example, they had recently made immediate ART available. So that's something to always be thinking about with the linkage. Having immediate ART initiation available can really increase that uptake as well. And then here with female sex workers in Uganda, they had a 3-arm trial where they looked at self-testing, social network-based distribution, as well as standard testing, and then offering self-test kits in facilities that female sex workers could pick up. And so what they found here is that the social network approach was achieving as good of or as high as positivity as the standard testing, but the facility testing pickup was definitely higher yield. So even a focused facility-based outreach model could work well if targeted towards these high-risk groups. And again, I just want to reiterate, with any of those service delivery models, it's important to identify the support tools that will match, considering the context you're in and the needs of the user. So it could be a variety of different options. I think with the social network-based model, sometimes the demonstration videos or the social media connections can be really effective follow-up tools and options. Something that may be community-based delivered might lend itself to something with a short in-person demonstration, but there's lots of different options to choose from. So to just transition a little bit to some of the experiences we're seeing just in the AMRA region, this is just to highlight some of the internet-based self-testing and broader programming coming out of Brazil. So we've seen now through their e-testing projects, so they have a website which offers self-tests so individuals can enroll and order a test for pickup through a mail order system and a variety of options. And they've been able to distribute a number of tests this way. And the site has been well received. So since 2014, with the data we had as of the most recent presentation given, was around 201 men who have sex with men had actually reported on their positive result. That doesn't mean that that's the only, the true number of people who have tested positive, but I think it's definitely an encouraging finding to see that people are sharing some information. And I think, to me, what was really encouraging about this experience was that the users kind of interacting with the site and accessing the website really reported having a positive experience and that they would recommend the site. And that 96% of those that were asked, they reported their main concern is that they wanted to order a larger number of kits, and access it more frequently. So something to be thinking about is perhaps this is a viable option for some settings to think about reaching different risk groups. And we also had an update given, I think around July at the AIDS conference, that in Brazil they're really scaling up some self-testing implementation and trying a variety of different implementation models. And there's a United-funded Fiotech implementation project on self-testing to generate demand for PrEP that's going to be ongoing. And a variety of new options. So I think a lot more lessons learned will be coming out of Brazil for sure in the region. And then just a few others that we've seen coming out of the literature. So in Peru, there was a publication that was looking at the acceptability and men who have sex with men and transgender women, really showing that there was a high willingness to self-test if it was offered for free, and really seeing that there was preferences for both that most preferred blood versus oral testing, the most preferred self-testing, and we see that a small proportion, they would just prefer facility-based testing. So that's still good to see that, there's going to be diversity. And 78% of participants preferred getting the self-test kit in a clinic or by mail. So another delivery model that could be potentially considered given a variety of different contexts. Now, in the article, they talked about how in Peru, there were some self-test kits. The oral self-tests were available in pharmacies for around $18, but the willingness to pay for self-testing was lower and closer to around $5. So I think something as well to be considering the cost issues for a private sector type of implementation model, some possible issues around subsidies or ways to bring that price down for consumers could be something to consider. But by and large, there was interest in self-testing across both groups. And likewise, I think we see similar trends in both Mexico and Argentina. And I think the interesting thing, in both of these is that we're seeing that, we're reaching men who have sex with men, and it's a group we might be reaching men who are not currently testing. And I think more work probably needs to be done to explore this in the region. Encouragingly, I think both Peru and Mexico are also piloting under a Unitate project, so something that might also provide more data and evidence for the region. And then lastly, there has been some forecasting in Central America that was done recently looking at the potential market, and they kind of highlighted in this very preliminary scenario that the NGO provided testing and online channels may be primary channels for self-testing with 24% share of total volume. So this is not a demand or procurement-based forecast, but it's definitely a scenario where I know a number of countries are looking at how do I decide which modality of self-testing to implement, and how can I think through which models might work best given my context. There's additional piloting going on in Haiti as well. If there are groups that are interested in learning more about that from JPIGO, I'm happy to connect folks, as well as landscaping activities and feasibility and acceptability studies also being done in Central America. If you're needing or interested in more information, a lot of the information in these slides, and that's always being updated, is hivst.org, which has evidence and policy information, so you can stay up to date and access the latest resources and tools. We also have our HIV testing info app. So if you're in the field and wanting to look up the latest recommendations on HIV self-testing, you can download this app and access it anywhere on the go. It works online or off, so it can be a helpful resource for you if you're looking at self-testing or other issues on HIV testing. Lastly, there's a number of additional resources when the slides are circulated that might be helpful to take a look into. And just want to thank everyone who contributed to this presentation. And if you have any questions, you can email me, and I'm happy to always discuss anything on HIV testing, and particularly self-testing. So thank you so much.
Thank you so much, Cheryl. Very, very, very interesting presentation, and I'm sure there will be tons of questions that we'll take. A reminder to you that if you do have questions, that you are encouraged to use the chat box to the right of your screen. A second reminder is that this webinar is brought to you through a partnership between the Pan American Health Organization and the Pan-Caribbean Partnership on HIV and AIDS. Next up, we have Dr. Ayana Sebro, and she'll take us through our next presentation. Dr. Sebro.
Thank you, Xavier. Afternoon, everyone. My name is Dr. Sebro, and I'm the Technical Director of the National AIDS Coordinating Secretariat in Trinidad. The presentation that I'm sharing is really just an amalgamation of the country's reaction to self-testing kits being available in the private sector over a period of 2 years. And so it really responds to some of the experience we've had. You would see some of our concerns about self-testing. So I'll just go through the gap in testing, the concept of test and treat in Trinidad and Tobago, some of the experiences, and really take you through what we've kind of been mulling over in terms of the spectrum of HIV testing and the issues that affect testing and different models of testing here in Trinidad. So this is a slide that you'll be very familiar with in terms of the testing gap, looking at where everybody is to determine, for example, where is everyone? The Caribbean is a region where there seems to be a high amount of HIV testing, but there is that gap in terms of people who haven't been tested. So in the Caribbean, 81,000 people are supposed to be in that gap, needing to still be tested. In Trinidad and Tobago, we have fairly high testing rates, but we still do have a gap. And so we've been trying to figure out where that gap exists. And for the most part, the testing gap would be for key populations. And in trying to react to some of the things that have been happening in the testing landscape, we've been thinking about what do we do and how do we respond in terms of testing scale up from the viewpoint of a package of opportunities for testing to be able to support key population testing. So sharing in terms of the populations that are concerned, and you'll see two populations there with a little asterisk. We have our substance users where there's a high prevalence of HIV, and the prevalence there has remained consistent. Then we have within that group, sometimes you have overlap between other groups. There are have been efforts to test people who are homeless, people who present with mental illnesses as well. And then you have the other persons who would be listed as key populations within our group. And I list here other populations significantly affected by stigma and discrimination and access limitations, because there are some populations that don't fall into our traditional key populations, but they have difficulty accessing testing or services because of rates of crime and violence where they may live. And so where can you access the testing, HIV testing Trinidad at this particular point in time? Well, this slide is really taken from the AVERT website, but you can get testing in our community health centers, as well as you can get tested at the family planning clinic or in a hospital clinic. If somebody does present to a rehabilitation service at this particular point in time, they would be sent to be screened in another facility to ensure that they can be tested. You can't get tested at this particular point in any of the youth centers apart from the one in FPAT, and there is no mail order. There's no service that's initiated in country for mail order of testing, but you can, there's nothing to stop somebody from going online to access a test from Amazon or wherever. And so in terms of determining what we do going forward with respect to testing, very much dependent on, for example, the prevalence of HIV here, the fact that the people that we want to test are members of hidden populations, we're looking to test members of the key populations. The human resource concerns in terms of how many testers can we train on our side, and then the system-related issues that would affect access to testing, like stigma and discrimination. So really, this is really about taking the test outside of the site for some of the clients, because there's some clients that definitely can't make it into a site and do need to get tested with some assistance. And so this is where there has been that discussion about self-testing. So in terms of being able to provide for people to really be tested, we have the doctor-patient model, which everybody is comfortable with in country. We have the testing, we have when we go out into the community site, so outside a hospital, you can go to a community center, you have a doctor or a nurse there, or a nursing assistant, everybody's comfortable with that. And we have roving sites where the testers go to different health facilities or they go out in the mobile. But once there is that involvement, the tester, and even the lay tester within that environment. So the lay tester doing a rapid test within the health environment where there's that kind of oversight, people are comfortable with that as well. When we haven't, so the only NGO testing site at this particular point is offered within the family planning services, and that's still within that patient nurse testing scenario, as well as you have some lay testers, but again you have you're still in that healthcare environment. So we haven't evolved to the point where we have lay testing NGO sites off on their own, and that's something we're still grappling with. And we have in private sector, we have some physicians who would offer testing within their facility, and then people can go privately and access an HIV test. So in that environment, through now a patient trying to test for themselves, and it brings up all kind of concerns within the response. And so there's the concept of somebody as a patient testing themselves using a rapid test, and this also would result in where the patient is testing, this would be a single test that the patient would have to access. There's the concept of the patient and partner testing, where one person brings a test to the other. I think that was some reference was made to that yesterday, as well as patients being supported by a support system, whether it be the lab or a private doctor or NGO lay tester in doing the test for themselves, and then the support system that's kind of in the wings supported the follow-up. And so this is some of the models that more people that seem to be a little bit more comfortable with. But for the patient actually testing themselves, there's been a lot of discourse around what happens in the private sector here. In some pharmacies in 2006, a self-test kit self-test kits were seen on the market. None of the ones that were shown in the previous presentation. And on that one, it says WHO approved. And so there is that also concern in terms of quality of test kits on the market that claim to be WHO approved self-test kits. So there's also that issue of not responding or not, internally would say, taking in front to make sure that whatever is available, if something is available, is actually what is being recommended by WHO, and addressing the big elephant in the room, which is the quality related issue and also the linkage to care issue. So I'm sharing this slide because I had an extensive conversation with a colleague over, in a recent meeting, looking at some of the qualifications for people who might be late testing. Because if it is we're going to say that we're going to even use, we're going to have NGO related testing or assisted testing, we need to be able to say, okay, this is what needs to be there, or this is what doesn't need to be there, and this is what currently exists for our late testers. Our late testers are supposed to be certified phlebotomists, and they have to have a quality assured. They have standardized training, and they also trained in the standardized reporting mechanisms of the Ministry of Health, and they use the standard algorithm. And this is all the late testers who are within the healthcare facility. But what would we need to do, for example, if we have someone who is assisting somebody doing a self-test kit? And these are some of the issues. It may not need to be this extensive, because a self-test kit needs to be used simply. And these are some of the things that have been coming up in their response. The biggest thing in discussions have been around linkage to care, and what would we do to be able to support getting a person who tests HIV positive using a self-test kit to be able to link to a facility. And then also, we've also talked about monitoring evaluation. So if you have a patient who is secure and can cope well, the patient is more likely to link, as well as if the patient is more aware of what's going on. Patient, again, is more likely to link. We've discussed the peer-to-peer model, because the peer-to-peer model is currently what is being used to help our key populations link even within the current testing modalities that we have available now. And there seems to be a fair amount of support that is needed for some populations to be able to link from getting a test, even to link to test, but getting the test and going to the service. And the need for more sensitization of the population of the services available, because if you want to get tested, where do you go? How do you know where to test, or how do you know anything about the quality of testing that you would experience, or how do you know where to link if you have questions about HIV testing? And then also, where is the psychosocial support in the community, psychosocial support at prevention and treatment sites to be able to support linkage to care, retention to care. And the linkage, really, the peer-to-peer model is so very critical in what we're seeing in terms of linking our key populations, especially those who might use substances at this particular point in time. In the private sector, I'm sharing a couple things, because within our system is at this point. In the public sector, we have a standardized algorithm, standardized test, but because there is no external standardization, there are different things that happen in the private sector. And in the private sector, we have, for example, there's one particular physician was advertising on Facebook that you can go to him, he would give you the test, you go home, you do the test, and then he'll call you and follow up to see what you got. And that is one scenario that I've come across, and that was on Facebook, and I looked for it yesterday and I couldn't find it. So maybe that he has changed what he's doing, but again, there is not that regulation around what's happening there. And he says he's had great success, and he's been linking his clients to the major treatment sites. In the insurance sector, another scenario that we have not been really we haven't engaged, where you, for example, the insurance agents actually do the test with the clients and as part of their processing for insurance, so that all the other tests get done in the lab or by the doctor, whatever. But the HIV test is between the insurance agent and the person who's pursuing insurance, and then depending on the test result, the patient either gets insurance or they don't get insurance, and they're advised to retest. There is not much of a network supporting this as well in terms of what happens quality-wise. The insurance sector has said that the agents go through training before they do this test, but this is something that's being done by one particular insurance company. In another setting, I would have shared about a client who actually went into a pharmacy who used a self-test, one of the ones that is supposed to be WHO approved, and she went ahead and she got tested on her own, and she was comfortable doing the test. But for this, she linked to care because of her past history of testing. So this was a person who would normally get tested and would be retested and was aware of all the services or the places still linked to. And there was still even a delay in her testing because she was in shock, disbelief. And so she actually retested 2 or 3 times before she presented to a treatment site. And then we have, in our scenario, we have a situation with the substance users, and we have substance users who, for example, the ability to test someone, you can only have them in a facility for a limited amount of time. And so this is a population that does need access to testing. The prevalence is high, as well as access to additional services to link to, because they can't link directly to treatment because there's that need for harm reduction engagements before persons can actually link straight to treatment sites. And so this population and being able to prioritize how you might want to engage with the population, this is an opportunity for us in terms of where, for example, some of the peer navigators may be able to use the testing kits as a means of screening or helping to triage persons that they might engage with and go. But so this is an opportunity for us with respect to the self-testing. But these populations are difficult sometimes to get into healthcare facilities. Sometimes they have no ID. Their attention span is short. You cannot, if you bring a lot of people in, you might be able to test one person, but you will miss some of the others. So there are those situations with respect to the self-testing. And so some of these are slides that you would have seen before, looking back at what WHO has recommended in terms of self-testing, in terms of the fact that it is highly accessible in different places. We're still grappling with self-testing and looking at how we can really ramp up linkage to care to be able to support multiple testing modalities using some of the actual practices that we have at this particular point in time. So that's kind of where we are trying to focus. We had a stakeholder discussion looking at combination prevention, discussing really where HIV, that whole spectrum of HIV testing, and we had several presentations on HIV testing, and generally there was this consensus that we needed to have a spectrum and of testing, and we need to be able to deliver quality and reliable testing, including self-testing. But we still also focused on that whole piece about the linkage to care and providing those types of services. The other thing was the importance of looking at the types of tests that we use and making sure that we have the actual tests that are WHO approved on the market, so that we can be able to advise what is available for use. So I think that is it in terms of the presentation. And just to share, the linkage to care systems that have been discussed have been the electronic, more so a media campaign, and as well the peer-to-peer services, and really looking at how we can link clients across the whole spectrum. Thank you very much.
Thank you so much, Dr. Sebro. Now, I'm happy your presentation came after Cheryl's presentation because, in a sort of way, it gives us the next set of questions that are important to answer. Cheryl, maybe you could help us with the answers for this one. Before I go with the questions, there is a poll up on screen. We encourage all our participants to respond. Question one, is there a list of recommended kits that are on the market, meaning a complete list? What is the percentage of linkage to care that we have realized based on where the self-test pilots have been implemented? And is there a standard operating procedure or recommended steps for follow-up for self-test kits?
So I'm happy to go ahead with maybe that. Is that okay, Xavier?
Sure, go ahead.
Great. So I think in terms of the list of recommended kits, so on the WHO website, we maintain a list of all of the WHO pre-qualified rapid tests for HIV, including self-tests. So if you're ever wondering, hey, this doesn't seem like a test I've heard of, let me check the WHO pre-qualification list to see if it's actually on there. There's only one product that is WHO pre-qualified at the moment, which is the OraQuick HIV self-test. An additional list to look at is the Global Fund. So they have a list, which I included in the resources link of my slides. So folks can go there. It's always good to check through their latest link because there's always updates of new things. And you can access anything that's approved for procurement under Global Fund. Now, what we will also have to consider in your own country context is that there may be something listed based on your own national regulatory system. So that, for instance, like in the US, you wouldn't see that product listed by Global Fund or WHO, but you would see it on the FDA list. So it's important to also check with your local regulators about that. In terms of the linkage to care question, when we really looked at the data early on, it did not differ initially, and this is not coming out of trials, but we didn't see differences in the national linkage rates compared with self-testing. So if you don't have good linkage, self-testing is not going to solve that because that's not really what it's designed to do. So it is important, I think, as Ayana was talking about, is you need to have a sense of what linkage systems work in your context and how self-testing can kind of be utilized to leverage those best. But I do think that we've got some good data showing that with a linkage strategy or a linkage intervention that's attached to self-testing, you can optimize linkage to care. So I know there was the home-based self-testing study where they had kind of had people who self-tested and were offered home-based ART initiation. They had a threefold increase in linkage to care compared to standard testing in a facility. So that's not telling you that self-testing has an impact on linkage to care, but saying that if it's packaged with an effective intervention, then you can have an impact. I think another component is that depending what we have seen in some of the studies and the trial data is the time period of how long can you track linkage from self-testing becomes quite challenging. So I would challenge maybe some of what Ayana was saying around, linkage could be poor. Well, it's also because maybe you're missing the data or you have not captured it, we don't know. And most of the studies I've seen, they have maybe 28-day or 1 month capture. So they're looking at from the time the self-test was distributed to when 28 days or a month later, what the linkage to care was. And sometimes people do need longer to link. And we've seen that, across standard services that may take up to 12 months or in some cases even longer for people to link. We certainly want to change that, but that doesn't mean that these folks may not link. I do think that the alternative to be thinking about with this question is if they never get tested, they also never get an opportunity to link. So this may be an additional opportunity to reach them. In terms of, go ahead, sorry.
All right. I have another 3 questions that I'm just going to read to you, and you could just tie it in your overall answer. These questions come from Delcora Williams in Antigua. It says, what level of psychosocial support is offered to a person before issuing testing equipment? 1, is this type of support necessary with this type of testing? And is it required for the pharmacist or the teller to prepare the person for a positive result?
So I think that with what those demonstrations I was talking about is those demonstrations can include some pre-test information similar to what we do with standard testing. So that would not be classified as pre-test counseling per se, but gives information of explaining what the test is, how it works, and giving some of that support. Now this will be dependent on the population you're trying to reach. So some of the context, if it's a younger person who seems distressed and in need of more support, I think it's something that, of course, being able to provide that support will be valuable, or even being able to say, here are some resources that you can access that are either locally available via the hotlines or other nearby social services. The pharmacist, I think it's going to depend on your national policies. I think it's great if the pharmacists want to do it. I know there's some countries where the pharmacists have really been the champions to say, we want to do this, we want to support this well, implement it well. And if that's the case, I'd encourage you to run with it. And I think if they're also feeling overburdened by the prospect of having to give a lot of that support, there could be some innovative models. So for instance, in one country, they had somebody that came in to do some light training. They had community workers or individuals that were available when they were just starting up self-testing to help with some of the demonstrations and implementation, and then they gradually phased that out. So it's something to think about, not as like a forever strategy, but something that you could do when just getting started.
Okay, thank you so much, Cheryl. 1 hour is hardly ever enough to explore all the issues or questions that will come up around self-testing. But as we wrap up this afternoon's webinar, here are some key considerations for you. We know that half of new infections are coming from key populations and their partners. We recognize that with self-testing, instructions are available, and so we're not randomly asking or issuing kits to persons. We also know that both blood kits and oral fluid kits are available, and we believe that it will optimize testing. The evidence says it has doubled uptake, it has doubled partner testing, and it has doubled the frequency with which people access testing. Important things for us to consider, guys. But that really does bring us to the end of this afternoon's webinar. I want to say thank you so much for having spent your afternoon with us. On behalf of the PANCAP Director, Mr. Derek Springer, the Knowledge Management Technical Working Group, again, want to say thank you. As a reminder, we will be recording, or we have recorded the webinars, and we'll post them on the PANCAP website. And do stay engaged, Facebook, Twitter, and look out for the new PANCAP redesigned website. Good afternoon, everyone.
Thank you, Xavier.
Thank you. Bye, everyone.